our immediate field. So without further ado, I'm going to hand over to Dr. Onodugo because she has the moderators. Dr. Onodugo, are you there? So Dr. Onodugo, can you hear me?
Yes, hello, good evening. I'm right here. Good evening, everyone.
Thank you very much. So please, could you read the citation of the moderator and then we'll hand it over to her. Thank you very much, Dr. Ekudu in advance and Dr. Titiloye. And we'll see you after look forward to the questions and answers later on.
Okay. All right, good evening, everyone. Thank you so much, Dr. Aisha. It's my pleasure to introduce the moderator for this session. She's Dr. Violet Udu. She's a chief consultant, physician, and dermatologist and academic practicing at Wuse District Hospital and Nile University of Nigeria in Abuja. She's dedicated to advancing dermatology practice, research, and patient care through evidence-based approaches. She's also passionate about teaching and mentoring and is committed to sharing practical insights that improve clinical outcomes. Ladies and gentlemen, please join me in welcoming today Dr. Violet Ebudu. Dr. Violet, please, over to you.
Thank you very much, Dr. Ododugo. It's my pleasure to be here. I also want to April webinar to out of your busy schedules to be here today. So you're all very welcome. Today promises to be quite interesting. I absolutely love the topic of April webinar. And we have somebody who has quite a lot of experience in this field, in this area, to do justice to this discourse. And we know quite well that the intersection of ethics, aesthetics, and patient expectations in aesthetic medicine is a delicate and complex terrain, yeah? And it requires thoughtful navigation by practitioners, all right? Even though aesthetic treatment sometimes the patients what they want much more than practitioners can give. So I'm going to give Dr. a lot of time to do justice to this, but I would like to introduce her and then let us start formally. A lot of us know her as Skin 101 doctor, but she's way more than that. She's an aesthetic physician, she's an educator, she's an entrepreneur with over 15 years experience in aesthetic medicine. She is the founder of the UNO Health Group, which is an ecosystem delivering healthcare services, clinical skincare, and professional training. She is also the lead trainer at the UNO Institute, advancing evidence-based policy and standards for aesthetic medicine for skin of color in Africa. So Hilda, welcome to our webinar, and I want to give the floor for you to your presentation. Are you ready for us? She was here earlier.
Yes, I'm still here. Can you hear me?
Absolutely.
Is my video showing? I'm not sure why. I can't see.
I can see you. We can see you.
Okay.
Share your screen again.
Can you see my screen?
No, we can't.
No, we
so
can't
just
see your screen
close
yet.
it and start again.
Okay. All right. Let me go to share again.
I can see you, but not the screen.
Okay. Can you see it now?
Yes, your slides are up.
Okay. Let me hide this. Okay. Okay, good evening, everyone. Thank you to the Nigerian Association of Dermatologists for this invitation. I am thrilled to be here. I'm always excited to talk about anything aesthetic medicine. So I have been doing this for about 15 years. I hold a postgraduate diploma in clinical dermatology and a master's in aesthetic medicine. Fortunately or unfortunately, this field or this area of practice has grown much faster than the rules that were written for it. We don't have any rules around here, but the rules are written for it globally. So this will be the outline for which we will have this presentation. And so let's start with the foundation. We already know dermatology is the medical specialty that studies and treats the health of the skin, subcutaneous tissue, skin appendages, the hair, nails, sweat glands, mucosal tissue. But unlike other organs, the skin is not just a functional organ. It's a medium of visual and tactile communication. How we perceive ourselves and how other people perceive us can be connected to our skin. So the dual nature, the biological function and the social surface is why aesthetic concerns exist within dermatology in the first place, and why it's also so clinically complex. Dermatology, of course, has three broad streams: medical dermatology, surgical dermatology, and cosmetic or aesthetic dermatology. Every dermatologist is meant to be trained across all three. Where they choose to concentrate is a matter of clinical focus, not a separate qualification. So, what's aesthetic dermatology specifically? It is a rapidly growing subspecialty of dermatology that applies medical knowledge, diagnostic skill, to elective procedures designed to enhance appearance or restore features that have been altered by aging or disease. So usually it's employed even when there is no formal pathology present. There is an intersection between medical necessity and patient wishes in aesthetic dermatology, and this is why ethics is so necessary in this space. The scope of aesthetic dermatology in current practice includes injectable treatments, your Botox, treatments for dynamic lines, dermal fillers for volume restoration and facial contouring, biostimulators, energy-based devices, lasers for pigmentation, vascular lesions, hair removal, radiofrequency treatments, procedural treatments, chemical peels, microneedling, thread lifts, intralesional treatments, cosmeceutical medicine, body contouring, all of them fall within the purview of aesthetic dermatology. Funny enough, there is no internationally accepted definition of aesthetic practice, and this gap has contributed to why there has been a lot of challenges with regulation, training standards, and ethical governance. If we cannot agree on what the field is, it's difficult to agree on who is qualified to practice it. So I'm talking about aesthetic practice in general now, not just not in the context of aesthetic dermatology. So let's look at the broader scope of things. If we zoom out from the subspecialty of aesthetic dermatology and look at it in a broader context, it becomes even more complicated. So aesthetic medicine is a wider umbrella term. It refers to the application of medical and, in some international contexts, non-medical techniques to improve physical appearance through minimally invasive or non-surgical procedures. It is not a recognized specialty in the way that dermatology or plastic surgery are, but it's a field of practice that has drawn practitioners from across all areas of medicine, dermatology, general practitioners, oral and maxillofacial surgeons, plastic surgeons, gynecologists, and in many countries, even outside, people outside the scope of medicine entirely. The American Board of Cosmetic Surgery has defined the field as a subspecialty that uniquely restricts itself to the enhancement of appearance through surgical and medical techniques. The UK Cosmetic Surgery Interspecialty Committee also defines it as sets of procedures that revise or change appearance or features that most would consider within normal range for that person. These definitions share one feature, that the procedures are elective with no pathology, and that is why ethical confusion exists within the space. So where aesthetic dermatology and aesthetic medicine overlap is shown in this slide. There are many things that are shared within the two areas of practice. So a patient seeking lip augmentation, brow lifting, or skin tightening may receive identical treatments, whether they see a dermatologist or a general practitioner. The procedure does not change. What may change is the depth of the practitioner's foundational training in skin biology, anatomy, pharmacology, and complication management. This overlap has created a real structural ethical problem, because you could receive great results from the aesthetic dermatologist or from the other aesthetic practitioners, and really the ethical burden of maintaining distinction within the practice falls on the professional themselves, not really on the regulator and not on the patient, on us. Now, the global spectrum of who practices aesthetic medicine is dependent on, we have found that, of course, it's dependent on area. The United Kingdom, aesthetic medicine was practiced by dentists, nurses, GPs, and non-clinicians, all legally until 2023. In the United States, nurse practitioners and physical assistants now constitute the majority of med spa operators in many states. In Brazil, in places like Brazil, physiotherapists are legally permitted to perform certain aesthetic procedures. Nigeria sits at an interesting position. On paper, only MDCN registered doctors can perform invasive aesthetic procedures. The framework seems to be more protective than most countries, and the distinction between what is legally permitted and what is commercially happening is very wide. We'll come back to this. Why we are trying to make this distinction this evening is because when we talk about ethical boundaries in aesthetic dermatology, we are not talking about a problem that is confined to non-physician providers. We are talking about a structural problem within the entire aesthetic medicine ecosystem. That's why we're taking out time to talk about, all of it. So it not only affects dermatologists, it affects general practitioners, aesthetic physicians, nurses, and patients who navigate this landscape without the training to distinguish between them. So the critical question is, who should be doing this? Is it about territory, or is it about the clinical ability to? So this is the question that we're going to answer today. Are we ethical enough, and for who? Let me move this. Ethics is the distance between what we're legally permitted to do and what we're clinically prepared to manage in the context of aesthetic medicine. Sorry. Okay. So it's the global aesthetic market was valued at over $15 billion in 2023 and is projected to double within this decade. Because it is so lucrative, you have people practicing aesthetic medicine everywhere now. In shopping malls, via mobile apps, in people's living rooms. And it's not a problem that is peculiar to Nigeria. We have already talked about how it's, even in the US, it's a bit lax from state to state. In the UK, they put some structure in place in 2023, just 2023. Were they able to put some requirements for mandatory training for anyone that is injecting botulinum toxin or dermal fillers? So it took years of documented patient harm before mandatory licensing arrived. In fact, they called it the Wild West because it was. Then in South Korea, it's almost a competitive pricing war. And aesthetic decisions are really driven by what a competitor prices, not what the patient needs. In Europe, there is some patchwork regulation across the continent, with their main problem is the counterfeit and unregistered goods flowing through the supply chains in the multiple markets. The global truth is that there is almost no universal ethical standard in aesthetic medicine. What passes as world-class practice in one country would be considered dangerous in another. So all of us, to some degree, are building the plane while flying it. You know, some countries are ahead of others with their regulatory framework. But Nigeria's situation is even more peculiar. Now let's come home. The Medical and Dental Council of Nigeria regulates medical practice under the MDCN Act, CAP M8 of 2004. And it's binding on every registered doctor. So several of its provisions speak directly to aesthetic practice, whether aesthetic medicine appears by name in the text or not. One, we have a duty of care, and I'll dwell a bit more on these because this is where the regulation and ethics lie. The duty of care and clinical competence. The MDCN code establishes that the duty of care begins the moment a practitioner agrees to examine or treat a patient. Rule 11A, the 12 Rule 11A of the 12 duties of a physician include the duty to provide adequate counseling, the duty to warn patients about side effects and treatment risks, the duty to carry out proper diagnosis, the duty to administer proper treatment, and critically for aesthetic practice, the duty to refer in good time when the clinical situation exceeds one's competence. Every one of these duties applies to aesthetic medicine. When we perform a procedure we are not trained to manage when it goes wrong, we are in breach. When we fail to refer a developing complication, we are in breach. The MDCN disciplinary tribunal can admonish or suspend or strike a practitioner's name from the register for these types of breaches. And more recently, we have now understood that MDCN proceedings do not shield the practitioner from concurrent civil or criminal liability. Then informed consent. There is a form that the MDCN have put together to guide us when we are taking consent in a way that we're not just taking a signature, but we are documenting, we are establishing that we have had a conversation with the patients and have documented what they understood and what we were able to pass on to them. So Rule 19 establishes informed consent as both an ethical and legal obligation. The MDCN acknowledges explicitly in the code that there is a universal consent format in Nigeria. A gap it's addressed by creating this particular form as the mandatory documented consent instrument for invasive procedures. The requirements are specific. All benefits and risks must be clearly presented. The preferred option must be chosen by the patient freely. For procedures that are difficult to reverse, a minimum of 3 counseling sessions are required with at least 4 weeks between initial counseling and signature. Discussion must be in a language that the patient is fluent in, and witnesses must sign. Even I have faltered in this area. It's good that I was able to use this as a way of refreshing what I know. Because typically a patient comes in, we have explained the procedure to them, we give them a consent, we further explain what's in the consent, and they sign in minutes. So the MDCN says it shouldn't be done that way. By MDCN's own standard, that is not an informed consent. It's just a document, and it will not protect us when things go wrong. The confidentiality. There is a Rule 8B and a before and after problem. So the Rule 8B mandates the utmost confidentiality of patient's information, including clinical findings, photographs, and anything disclosed within a clinical relationship. We have in the 1999 Constitution of the Federal Republic of Nigeria, there's a section 37 that reinforces the right to privacy. In aesthetic practice, this means that before and after pictures on clinic, social media, even when consent is obtained, sits in a contested zone. Consent obtained in the treatment room within the power differential of a clinical encounter may not constitute free consent. There is actually there is a new document from the MDC and the 2025 MDC and social media guidelines that reinforce that practitioners are personally responsible for all posted content, and deleted material may still be recovered for regulatory purposes. I'm going to put up the new social media guidelines on the group when the presentation is over. So we all have, because I only found out about it maybe 2 weeks ago. I don't think many of us have it, but it will help to guide this before and after situation and help us navigate it better. Now, advertising and the Part F dilemma, I call it. So we have the Part F of the MDCN code prohibits registered practitioners from publicly advertising their services. Only patient information leaflets within health facility premises are permitted. Practitioners cannot use their photographs or credentials in promotional activities. We are not permitted to broadcast or write articles with promotional intent, and we cannot make favorable comparisons with other providers. So this, many of us have found one thing here. Because there are many, the other issue is because there are many non-physicians that openly advertise their services, it puts you in a corner where if you want to be seen, you feel you need to advertise in that way, but it's prohibited by the Medical and Dental Council. I'll come to what the Medical and Dental Council permits, but that is prohibited. So let's look at the scope of practice. only MDCN registered doctors can legally perform invasive aesthetic procedures in Nigeria as of right now. Unlike other countries where nurses can perform those services, physician assistants can perform them, in Nigeria as of right now, only MDCN registered doctors can. Any facility that is offering injectable treatments must have an MDCN registered physician as medical director with documented clinical oversight. So I'll talk about when it comes to regulating the practitioner and then regulating the facility itself. In regulating the facility, I know in Lagos they have the HEFEMA. In Abuja, we have Firm C, the primary healthcare regulatory units from the FCDA. I don't know about what completely obtains in Lagos, but in Abuja, what is permissible now is that for anyone to have an aesthetic medical facility, there must be either a dermatologist or a plastic surgeon as part of the supervising physicians. So yes. Now, we talked about consent. I talked about consent earlier. Normally, I think we do the consent more as a theatrical, need rather than how the MDCN expects us to do it. So it's usually just, we have the consultation, we give the generic form, the patients sign based on what we have, explained to them. But remember that especially for procedures that are irreversible, you need to give time for the patient to think through it. When they are coming to sign, it means they have understood, and it means you have explained the risks and benefits. You have explained substitutes for that, or alternatives to that particular procedure. And the patient has understood in a language that they are fluent in. Okay. All right. So this is also new. The Federal Consumer Protection Council, there has been a recent development that I don't think many people know about. This was just passed on the 15th of April. There was a judgment in the case of LifeBridge Medical Diagnostic Center versus the Federal Competition and Consumer Protection Commission. So what the FCCPC have been pushing for is that medical facilities should have some oversight over how medical facilities over consumer rights within medical facilities. So what has now happened is this case has been on for a while, and there has been a ruling that has confirmed that the FCCPC have full legal authority to investigate patients' complaints against healthcare providers, including clinics, hospital, diagnostic centers, under the FCCPC Act of 2018. No formal agreement with the MDCN is required, and no commercial medical practice is exempt. So in the past, a medical provider found wanting was, only under the jurisdiction, under the professional discipline of the MDCN, but it's not so anymore. So now there are we have a dual liability matrix now, where the MDCN governs professional conduct and clinical discipline, but FCCPC governs the consumer fairness and service quality. So, sorry, a dissatisfied client can now run, oh my, sorry, I touched that screen. A dissatisfied client can now run 2 independent regulatory tracks concurrently against a single clinic or practitioner. Now, 1 minute. So the areas where we are typically found wanting. 1, the competence gap. Globally and in Nigeria, this area of aesthetic medicine is growing faster than the training systems that exist for it. The MDCN code requires that you refer when a situation exceeds your competence. But usually you can only recognize your limits if your training was rigorous enough to define them. So the solution is not to restrict practice, it is to build training that truly covers, that is truly robust enough to make us competent practitioners. Then we talked about the consent theater. Signatures that are consent that is taken hurriedly provides 0 legal protection. The social media tightrope, even I found wanting here. The dangerous blur between clinical education and illegal outcome guarantees, because part of what the FCCPC would hold us accountable for is that when we make certain promises on social media, that we have guaranteed to some degree that those are the outcomes that the clients or the patients would get. Then the equity blind spots. Sometimes, especially when we for people that do a lot of procedures that involve equipment and the like, a lot of the equipment that we have, a lot of the clinical trials and the clinical evidence that we have for what those equipment do is not entirely based on our skin type, right? So we also have to know that we cannot rely on clinical evidence bases that are built for other skin types. This has to be constantly in our subconscious. Then the everybody does it trap. It's easy to see everybody making progress with the activity, be it on social media, and normalize those violations. Because if you don't come back to constantly check or have in your subconscious that this is what is permitted of you as a medical practitioner, it's easy for you to fall into the trap of everybody is doing it, so why can't I? But you see, now we have not only the MDC to answer to, we also have the FCCPC to answer to. So the rules that govern our practice are different compared to the rules that govern the others. So what can we do right now to improve on our practice and make us more ethically binding, or ethically make us show that we are thinking about ethics in everything that we do? So we're meant to actually verify every product, every professional product that we use. We check that every injectable has NAFDAC registration. This is going to be a bit difficult because we don't have so many suppliers. I know that many people import whatever they use independently, but we are having a few suppliers coming to the country now. So if we were to keep asking for this, they would likely go back, even if they don't have, they would likely go back and get this NAFDAC registration for the things that they bring in. Then we need to look at our consent forms and how we take consents. Then ask the patients questions, critical questions. What are they hoping will change, from the
Yes, Hilda.
procedure?
Yeah,
Yes, please.
this is also interesting. But sorry to let you know, you have about 10 minutes more.
Okay, I'm almost done.
Yeah, so I think
I'm almost done, actually.
yeah.
We need to audit our clinical edges. Any procedure that you do that you cannot independently manage, if it fails, you should seek more training for. Then screen your social media presence against the October 2025 MDCN guidelines and the FCCPC consumer promises. Then we should establish complaint pathways. There is actually a complaint pathway that the FCCPC mandates for all providers. There is a process, 48-hour documented response process protocol for unhappy patients, and we should have them, and documents when we have complaints. Then we should ensure that our MDCN documentation, our licenses are always up to date. To protect ourselves, we have to. So yes, this are my references. And yes, thank you for listening. I will wait for any questions. And yeah, that's that.
Yes, thank you, Dr. Hilda. That was quite, yeah, it was extensive, yes. And then see all of the emojis, yeah, the raised hand, the hand claps, all of them telling you well done for your presentation. Yes,
Oh.
very good. Now, yes, so this was really good and in fact quite eye-opening. And I'm sure a lot of information you presented today, some of us were not aware. And then the case in point, the FCC PC1.
FCCPC.
Yes, FCCPC, yes. So we had an experience actually in our practice. And the thing is that what I take home from here is that, look, if you're not sure of regulations, before the patient goes to even make a report, you find out what you were supposed to do and what the issues are, and then you can take steps to correct that. And so we actually reached out to the FCC. It's like, this is what we have on ground. This is a complaint the client made. And they told us, look, the patient doesn't have any case. And that was that. And that was the end of that. So I think it's quite relevant, okay, to know what the jurisdictions that cover practices. And then I think I'll just do like a quick recap, not really, because I think you touched most of the topical issues. But where I feel maybe the questions may come from, because I have questions even, it's about managing vulnerable patients. For example, like even in clinical practice, you have patients who come in and will tell you, oh, look, doctor, I'm coming in with a picture of Angelina Jolie. I want her lips. And then you have to give me Angelina Jolie lips. How do you manage those kind of cases? And of course, you mentioned the consent form. Yes. And then also the social media. And the social media is an extension of your practice. You cannot say, oh, this is just for me to advertise and let people know. Yes, according to the law, it's a part of your clinical practice. So you should be able to make sure your practice on there is ethical, right? So and also financial ethics. I also have questions about that, just in case others don't ask. Financial ethics, transparent pricing, for example, recommending only necessary treatments. Those are our own responsibilities as practitioners. Okay, so but I don't think I need to spend, because time is far gone. I don't need to spend a lot of time recapping on all of this. I think we got most of the messages and then the information you wanted to pass across. So I'm just going to leave it open for questions now. If you have any questions, we can ask Dr. Hilda. And then if anybody has a contribution, an experience they've had, okay, and how we can navigate from there. Thank you. Any questions, please? Oh, okay. I can see the 7 messages in the chat. Yeah, so Dr. Zainab is saying thank you for the nice presentation. And she said she would like to know, I think, yeah, your message is not complete, doctor. Dr. Zainab, you can unmute yourself and ask the question because your message is not complete. I can't see it fully in the chat. Okay, so let me just start by asking, okay, about a patient who has a body dysmorphic disorder, for example, okay, coming to seek aesthetic care. How would you interact with that kind of client? Dr. Hilda, yes.
So, we have had a few patients we believed had that. And ideally, you're supposed to manage with the psychiatrist. That's the ideal thing you're supposed to do. We find that we end up losing those patients because they probably find someone that would give them what, we refuse to. But once you identify that, there are just patients that complain about the slightest asymmetry, even when it looks perfect to everyone, they find faults in it, in whatever it is that they're complaining about. So those patients, if you have a high index of suspicion, that you explain the situation to them. I think you might be having this, and it's unrealistic because you're not going to get what you are hoping to get eventually, the perfection you're hoping to achieve.
So you want to work with the psychiatrists to manage
Yes, I have actually reached out to psychiatrists about one patient, but I lost her to
follow up. Yes.
follow up. Yes, they would find someone that would fulfill their needs.
Okay,
But if
so
you are
how
stern enough,
how can dermatologists balance ethical practice with business growth? You understand? That is one question. If I don't do what they do, how do I meet up? How will I get clients coming to see me? So how can we ethically balance business growth with ethical practice?
You'll be surprised that there are people that are looking for your type of practice, someone that will tell them exactly what they need and what they don't need. There are patients that tell me that I am just someone that likes saying no a bit too much, because if truly I don't think you need it, I'm not going to do it. So when they realize that this is how you practice, what actually goes around, oh, this doctor will not just do just anything because you say you want it. And that becomes your reputation. And there are people that will seek you out for that quality that you have. So in my experience, I will not say that has been so much of a problem.
Awesome. So Dr. Becky Obasi is asking, do we need to take written consent to take images of patient's skin in the clinical ward, or verbal consent is sufficient?
Sorry, I didn't. Written consent to take?
She's asking, yes, take pictures of our clients. Do we need to take written consent, or verbal consent would suffice?
We take both written and verbal consent. We take written consent for everything. So the consent for pictures can be part of the consent for it can come in as it doesn't have to be a separate consent. It can be part of the consent for whatever procedure it is you're doing. If you're talking about consents for So we also take pictures just to monitor progress, right? In that case, we take verbal consents.
All right, thank you. Dr. Cole is asking, how do you manage providing newer trending aesthetic treatments with minimal evidence base? Okay, and then saying the field is expanding rapidly, but a lot of new treatments have limited evidence of their safety or efficacy and have no guidelines, e.g. exosomes and PDRN. So how do you balance exploring such treatments with data evidence or evidence constraints?
It's similar to when you're using off-label treatments. You have to tell the patient, this is what this is meant to do, but there isn't enough research that backs it up, unlike this other type of treatment. And the buck lies at the end of the patient. You explain to them. If they're okay with it, it's good and fine. They go. Many patients will want to read up about things, research on their own. If they're okay with it, it's fine.
Okay. So back to Dr. Zainab's question. She says she'd like to clarify if other doctors can use license or must still be a dermatologist or plastic surgeon for a med spa, I guess opening a med spa. If other non-dermatologists or plastic surgeons can open a med spa. I think that's what she's asking.
So, I explained that it's different for different places globally. Even in the US, different states have different expectations, recommendations, and restrictions. In Nigeria, there isn't there isn't a regulation that covers the whole of Nigeria. So what I find is in Lagos, it's slightly different. In Abuja, it is slightly different as well. I know in Abuja, you have to do, even if you're not doing injectables, as long as it's a med spa and you're doing chemical peels, etc., there must be an oversight by a doctor that has residency training in dermatology or plastic surgery. So what I understand they're trying to do is also expand it into other doctors that have at least 10 years post graduation experience, but I don't know how far they have gone along with that.
All right, and then
But this is in Abuja.
Dr. Esther Edwards, I think this is more like a suggestion anyway. So she's asking if you can make a special aesthetic training sessions for clinical dermatologists with special consideration for that. I think this is a private conversation, I think, with the NADESCO. So, but just take note of that and maybe something you can work out. So Dr. Aisha is asking, the issue of psychodermatology, I think this is more of a comment. The issue of psychodermatology still remains. We don't have experience and specialists in this field. We lose patients once we mention psychiatrists. Unfortunately, yes. Very correct. I ran a clinic today, and then a patient came in, and then she had Pica's words. So at the end of the day, she had just lost her husband, so she was depressed and all of that. So it was sort of like a coping mechanism. So I had to do a referral to a psychiatrist, but I can assure you that's the last time I'm going to see that patient. You understand? It is what it is. But this is something we need to do. Yeah, we need to have this conversation about psychodermatology. You understand? Yeah, and then quality of life issues. This is still a big topical issue in dermatology. Yeah, that's a good one, Dr. Aisha. All right, so I don't know, can I take one more question? I just wanted to ask you, okay, what are the common or the most common ethical issues you come across practicing, as a private practitioner? What are the dilemmas that you face the most?
I think it revolves around social media expectations. Because the way aesthetics, they call it aesthetics now, right? They have even removed the medicine from the conversation. It's now aesthetics. So people, equate it to almost a salon-like service, any other beauty service. You just go, the way you go do your lashes, that's the way you will come fill your lips, right? So I think it's the way it's been watered down to being, just like any other beauty treatment. And it carries real complications and risks. I'll even give an example, maybe one of the commonest, not the commonest, but let me give an example of a dilemma we had this morning with a patient that came and wanted one of the GLP one weight loss treatments. And for us, you have to run some tests because we need to know where you're coming from. So we have something to, check over time. What's the reason why you even want this treatment? And she got really upset. The patients get really upset when we tell them that they need to run some tests, because everybody is buying the thing over the counter. Why is ours different? And we try to explain that this is something that's going to change your metabolism, it will change your physiology, it will change many things. We need to have an idea or a picture of what's happening within you before you start off this medication. And it's always such a huge,
Yeah, it's a sore
always
issue for
such a
both of
big
them.
thing.
Yes. Yeah.
It
Because they
seems
really
to be
don't
very
want
difficult. Yes,
what
yes,
you need to
yes.
get done. You need to
Very
get your markers, you need to get your CRP, C-reactive proteins, you need to get your baseline, LFTs, your renal function, all of those things are mandatory. But what you find, in fact, I saw something on social media recently, somebody who I don't think is a medical doctor was like in broad daylight, just actually injecting somebody's abdomen. I'm like, is this person a doctor? And how are you even doing this so openly and nobody's saying anything? The issue of regulation is a big one. It's a big one. You understand? And I think now it has actually taken like concrete steps. As regards to that of good issues, but I think this is something that maybe NAD needs to also look into, and then find a way to at least let's see if we have guidelines, and then sort of like a supervisory role. You understand, to reduce the amount of quackery that is going on there in the social media. Clearly out of time. We are out of time.
Okay, let me just say a little something before we close. So personally, I don't think it's a lack of regulations or a lack of guidelines. I think it's a lack of enforcement, just like everything else in Nigeria. So, because the practitioners are bound by the MDCN, the FCCPC, because, that's our regulator. The other
Then
people are not bound by anything.
who regulates the med spas?
So they are not really bound by anything. I
Yes.
think what might possibly cause a shift would be the consumers themselves. When they know that this is where they should go and this is where they shouldn't go. When they know that they should ask for, okay, are you a doctor? Are you a nurse? Who are you? And what has given you the permission, or what has empowered you to provide this treatment? I think when the consumers start asking those questions, that's when we would have maybe some control in the space. But
I think
otherwise,
this conversation is something that needs to be had. You understand? And I think us medical practitioners, I think we need to make our voices louder. We need to make our voices louder. So, and it's not something that we will get results in 1 year, but it's just to continue and be consistent, and hopefully people will hear and then start to ask questions about who their practitioners are. Yeah, and yes, I agree with you, Dr. Chito. You say thank you for your presentation, Dr. Hilda. It's been super enlightening. Yeah, so it's 6 p.m. on the dot. So we can give virtual rounds of applause for Dr. Hilda. All right, so well done, Doctor. It's been really good. Yes, yes, yes. The rounds of applause are coming. Can you see them?
thank you. Thank you.
All right, so I especially want to thank everybody for being a part of today's webinar. I wish we actually had more time, and I'm sure a lot of people had a lot of questions to ask, but unfortunately we're out of time. I want to thank the NAD executive for asking me to moderate this session. In fact, it's been quite super enlightening, and I've enjoyed myself and I've had a good time. Thank you, Dr. Hilda, once again. Hopefully, when NAD calls on you, you'll be available to to come back and have this more conversations. Yes.
I'll try.
Yes, I think. Thank you. So I think in the absence of any other no housekeeping, I think I'm supposed to hand over to the person that introduced me. I think that's Dr. Aisha. So Dr. Kudu signing off. Thank you very much. Is she on here?
Okay, yeah.
Okay,
Dr.
Dr.
Aisha.
Perfect.
Okay.
So,
All right. Thank you so much. It has been super, super, super enlightening. Thank you so much, everybody, for joining us this evening. Thank you to our speaker, Dr. Hilda, and Dr. Ebudo for anchoring this session very superbly. I know we've learned a lot. The discussion continues right there in the NAD forum and in all our social media handles. Please don't forget to follow NAD on Instagram, on YouTube, and all our social media handles. So I guess this brings us to the end of this month's session. We'll be gathering again in the near future to discuss something even more interesting. Thank you all so much and good night.
Thank
good
you.
night, all. Yeah.
Good night.
Thank you, Dr. Hilda.
Thank you.
Thank you. Thank you.
Thank you. Good night.